Good afternoon, everyone. So, welcome to this PSMID PhilCAT collaborative initiative. And I would like to introduce the chair for this particular session. It is indeed the pleasure of the group that he agreed to chair and to moderate at the same time. So, let me welcome the Executive Director of the Lung Center of the Philippines, Dr. Vincent Balanag. Vince, the floor is yours.
Good afternoon to everyone, and welcome to this session on the clinical practice guidelines for tuberculosis in adults 2020 updates. So, hello, I'm Dr. Vincent Balanag. I'm a member of the 2020 TBCPG Steering Committee, and I'm very glad and honored to chair and be the moderator for this session. This session is sponsored by the Philippine Society of Microbiology and Infectious Disease and the Philippine Coalition Against Tuberculosis, or PhilCAT, who are the main proponents of the project together with the Philippine College of Chest Physicians. This session aims to present the most recent consensus statements and recommendations on the screening, diagnosis, treatment, and prevention of TB in adults. We will compare the latest consensus in 2020 with the one in 2016 on TB and the sixth manual of procedures by the DOH and TP, and to provide updates on the TB notification by both public and private healthcare providers. This session is scheduled for 2 hours, and we have 8 resource speakers, all prominent names in the TB field who are either members of the steering committee or chairs of the respective technical and working committees in the TB update. The session is divided into 2 parts. The first part will comprise the first 4 speakers who will talk on screening, diagnosis, and treatment, to be followed by a 10-minute open forum. While the second part will be a presentation on MDR-TB, LTBI prevention, and notification, followed by another open forum. We won't be able to attend to all your questions during the open forum, but we encourage everyone to use the chat box during and after each presentation. And our speakers will be willing to answer your questions in the chat box. So we are requesting the resource speakers to stick to their time allotment so that we can end the session promptly at 3 p.m. So without further ado, I'd like to introduce the first 4 speakers. We have Dr. Regina Verba. She is business manager and board member of the PSMID, associate professor for University of the Philippines College of Medicine. She's also the chair of the Hospital Infection Control Committee and Division Chief Section of Adult Medicine of UPPGH, Chief Section of Infectious Disease, the Medical City, and consultant and chair of the National Steering Committee on the Antimicrobial Stewardship Program of the Department of Health. She will be followed by Dr. Mario M. Panaligan, who is the current president of the PCP, immediate past president of PSMID, Board of Advisors of the Philippine Hospital Infection Control Society, assistant professor of medicine at the UARM, assistant head of training and research and chief section of infectious diseases, Department of Medicine, St. Luke's Medical Center at Global City, and medical specialist 2 and head section of infectious diseases, Department of Medicine at the Jose Reyes Memorial Medical Center. Next will be Dr. Janice Kawili. She's the chair section of infectious disease, Department of Medicine, Makati Medical Center, head infection prevention and control Department Head, Center for Travel and Tropical Medicine, and Research Consultant of the Tropical Disease Foundation. She is currently board member of the PhilCAT and secretary and board member of the PSMID. The fourth speaker for the first part is Dr. Gemeline U. Garcia. She's the chair of Pharmacy and Therapeutics Committee of RITM, also the chair of Antimicrobial Stewardship Committee of the same institution. She's also the chair, Antimicrobial Stewardship Committee of Asian Hospital and Medical Center, chair, also Antimicrobial Stewardship Committee of the UniHealth Southwoods Hospital, and member, Internal Medicine Residency Training Committee of the Las Piñas Doctors Hospital. So without further ado, I'd like to introduce again Dr. Regina Berba, who will talk on the burden of TB according to the WHO Global TB Program and an introduction to the CPG. You have the floor, Nina.
Hello, good afternoon, everyone. So let me introduce the methods that we did to start off and develop the updates on the clinical practice guidelines for tuberculosis 2020. So why do we need to update the Philippine CPG for TB in adults, and why is it a priority? Considering that we only had the recent TB guidelines in 2016, there were many events globally and in the local setting that steered us to make the updates a priority. So in 2014, the World Health Assembly actually announced the End TB strategy. And in 2017, there was the release of the National Prevalence Survey, which were all very, very important findings. And by 2018, the Philippines, through Health Secretary Duque, committed to find 2.5 million cases and treat them. And this year, the 6th National TB Program Manual of Procedures, or the MOP, was released. And of course, we're here in the midst of a COVID-19 pandemic. So it's important that the NTB strategy, which was launched in 2014, actually steered all of us into urgent action because the vision was very, very ambitious. A world free of TB with zero deaths, disease, and suffering due to TB. And the goal was to end the global TB epidemic very soon. So there were indicators that were set. And actually, next please. We needed to reach the targets on time, like a drop by 80% in new TB cases by 2030, a drop by 90% in the people dying of TB by 2030, and to reduce poverty and catastrophic costs by 100% by 2030. And then in 2016, there were these very disturbing findings from the National TB Prevalence Survey that told us that the findings they had told us that there was no evidence in a decline in the TB prevalence from 2007, which were many decades ago, to 2016. So that by itself was very disturbing and prompted us to really double time in terms of action against tuberculosis. Next, please. And during the United Nations high-level meeting, Health Secretary Duque actually pointed out that it was very important for us to find and to treat 2.5 million Filipinos by 2020. So there was really a need for some updates in the current TB clinical practice guidelines. Next, please. So the objectives of the CPG update was to update the current CPG that was completed in 2016 and put forth in light the new developments from the global and the local setting, and only study the evidence that came about between 2016 and 2019, and to provide further guidelines on the current burning issues to assist clinicians and other TB personnel on diagnosis, treatment, prevention, and control of TB. Next, please. So we follow the methodology that was advised by the Department of Health. We started off identifying the gaps from the 2016 TB-CPG. We didn't want to reinvent the wheel all over again. So we studied the 2016 guidelines and looked what needed to be updated. And together with PhilCAT, PCCP, and PSMID, we had a steering committee and came up with a list of 18 questions which we considered burning issues. And we asked the opinion of the Department of Health on the importance and urgency to update these questions. So these are the questions which will be tackled one by the speakers that follow me. Next, please. So this is the list of the steering committee. You might wonder how we were privileged to be part of the steering committee. So historically, myself and Dr. Balanag were the chairs of the 2004 TB-CPG development. And then the 2016 CPG was headed by Dr. Mortera. And of course, Dr. Jubert was always there, and Dr. Marisa Alejandria was part of the TB prevalence survey. So we declared that we had no conflict of interests as members of the steering committee. And then we formed a very powerful technical writing committee group. So for each of the domains of the questions that we formulated, we had a whole committee that looked for the evidence behind them. And they will be presenting one by one. So if the 2004 CPG took us like 18 months to put together before our first draft, and the 2016 guidelines took like a year to put together before the first draft, this one, the one that we did last year, only took like 3 months. It was really a very efficient, powerful, well-funded type of work. They had an extensive literature search, and then they were able to study the new evidence and then summarize everything through recommendations. The evidence of each question was presented in three parts. There was a summary of evidence that was summarized, and then the evidence tables using the grade system was also presented, and forest plots as needed were put in place. Next. For diagnostic questions, we needed to have likelihood ratios. And for associations, we needed to present direct evidence. Of course, the grade system was, again, next please, was something that was very important. This is the grading system that Dr. Lansang talked about during the plenary 4. And then we went through this consensus stakeholders last December of 2019. In this, we called in the panel of stakeholders. We underwent Delphi voting, and recommendations were based not only on the quality of evidence that were presented, but also took into consideration the balance between desirable and undesirable effects of the recommendations, patients' values, cost and access to tests, and potential implications to patients, clinicians, and policymakers. Next, please. This is the list of the consensus panel of professional societies. Next. And then we also had patient groups, the Samahang Lusog Baga and TB Hills. The Department of Health was also an important part, and some other NGOs. And this is the photo that we took of the consensus panel meeting in December of 2019. Because of that meeting, we were already able to put together draft of the evidence-based recommendations, of which you will be hearing about today. And then through the next few months, through the COVID pandemic period, we actually ask the help and the opinion and the advice of our resource persons and external reviewers. The list of that is in this slide. Next. So today is all about presenting for the first time the recommendations of the TB-CPG update to the public. Thank you very much.
So I'm tasked to discuss updates in TB screening. Next, please. The first question is, among adults with no symptoms but with high risk factors for pulmonary TB, how, how accurate is screening by chest X-ray in identifying individuals warranting bacteriologic workup? So if we recall, the 2016 CPG recommendation mentioned that together with a good clinical history, a good quality chest X-ray film is needed to initially guide the clinician in the identification of presumptive PTB for further bacteriologic confirmation. Now, in the most updated Manual of Procedures, that's the 6th edition, they recommend screening by chest X-ray annually among all health facility consults, including congregate settings, targeted communities, and workplaces. Now, in the 2020 CPG recommendation, we recommend among asymptomatic adults with risk factors for pulmonary TB, the chest X-ray is accurate screening tool with a 93.8% sensitivity and is recommended to identify individuals warranting further bacteriologic workup. So this is a strong recommendation with a moderate quality of evidence. Next, please. So there were actually no studies that, can you go back one slide, please? There were no studies that directly assessed the accuracy of chest X-ray compared with the other diagnostic methods in asymptomatic patients with risk factors. Now, a TB prevalence survey in Kenya with an HIV prevalence of 14.9% showed that the presence of any abnormality in chest X-ray had a sensitivity of 94% with a confidence interval of 88 to 98, 92% in HIV infected, and 100% in HIV uninfected, and a specificity of 73%. However, the study did not stratify patients into asymptomatic and asymptomatic patients. Next slide, please. A systematic review investigated the number needed to screen to detect a case of active TB in different risk groups. Of the many combinations of components of screening algorithm, the presence of chest X-ray in that consistently resulted in lower number needed to screen. NNS was lower when chest X-ray was used as primary screen with an NNS of 27, or as a component of the screen with an NNS of 37. In contrast, higher NNS values were found in strategies that use symptom screening alone. As you can see, with an NNS of 142, or if they did not use chest X-ray with the NNS of 73. Next, please. So this review showed that using chest X-ray versus not using chest X-ray yielded lower NNS among HIV/AIDS, that's 8 versus 54, household contacts, that's 17 versus 54, and of course the homeless subjects with 67 to 70 versus 455. Next, please. So the NNS presented may that this can provide guidance in setting priorities in the local context, especially in settings where the resources are limited and the incidence of TB is high. So you can see that we can prioritize this modality among HIV infected, elderly, household contacts. Next slide. So the 2016 National TB Prevalence Survey showed that the proportion of TB cases who reported they had diabetes mellitus was higher, that's 8%, versus those who are non-cases, that's 4%. There were also more cases of TB identified among those with history of smoking, that's 67%, compared to non-cases, 39%. Of course, they did not perform subgroup analysis for these risk groups as to the accuracy using chest X-ray in asymptomatic individuals. So the survey concluded that risk groups should be targeted and recommended studies on cost effectiveness of chest X-ray screening can be done among these risk groups and individuals at high risk for TB. Next. So the WHO end strategy includes systematic screening for active TB in high-risk groups. So WHO strongly recommends systematic screening for active TB in household contacts and other contacts of people with TB, people living with HIV, and people exposed to silica. Systematic screening should be considered in people in prisons and other penitentiary institutions, in people with untreated fibrotic chest X-ray lesion, in geographically defined subpopulations with extremely high levels of undetected TB, in highly endemic country, and in some populations that have very poor access to healthcare. Next, please. So the second question is, among adults with no symptoms and no risk factors for TB, how accurate is screening by chest X-ray in identifying individuals warranting further bacteriologic workup? So again, looking back at 2016 CPG recommendation, same. Good clinical history plus a good quality chest X-ray film is needed to guide clinician on the identification of presumptive TB for further bacteriologic confirmation. Now, the current manual procedures says that systematic screening in facilities shall be done for all clients visiting the facility regardless of reason for consult. For those who do not have any of the cardinal signs or symptoms for less than 2 weeks, you can offer chest X-ray screening if one has not been conducted in the past year. Now, the 2020 CPG recommendation says or say that among asymptomatic adults without TB risk factors, there is no evidence demonstrating the accuracy of chest X-ray. However, because of the high prevalence of TB locally and considering that around 10% of bacteriologically confirmed TB had no risk factors and no symptoms, chest X-ray is recommended as a screening tool for identifying individuals warranting further bacteriologic workup. Next. So, looking at the pooled estimates in studies cited by WHO and another systematic review, chest X-ray had a higher sensitivity for detecting pulmonary TB in the general population compared to symptom screening. Now, these studies were not designed to evaluate the diagnostic accuracy of chest X-ray, specifically among asymptomatic individuals not belonging to high-risk groups. Next, please. So, looking at the data from the NTPS 2016, among the survey cases with chest X-ray findings suggestive of TB, majority, that's around 67.5%, were negative for screening symptoms such as 2 weeks cough and or hemoptysis. So only 133, that's 28.5% of the survey cases were both positive or were positive for both symptom screening and chest X-ray. So you can see that during the active case finding scenario, screening for TB using symptoms alone would miss around 1/3 to 2/3 of cases, and therefore we actually can use chest X-ray as part of the screening tools that we can do for further bacteriologic workup. Over to you.
Thank you, Mario. May I please request for remote control? Okay. Maurice, I cannot see the remote control on the screen. May I request my first slide to be projected? The remote, okay, thank you. So good afternoon, everyone. I will be presenting our consensus statements and recommendations for TB diagnostics. Next slide, please. Okay, so the first question is, among adults with presumptive pulmonary TB or PTB, how accurate is sputum expert MTB RIF compared to direct sputum smear microscopy or DSSM in establishing the diagnosis of pulmonary TB? Next slide, please. So we are all familiar with the expert MTB RIF. It is an automated cartridge-based nucleic acid amplification test for TB. It detects M. tuberculosis as well as mutation that confer resistance or that confer rifampicin resistance. The assay provides results directly from specimens in less than 2 hours. The 2016 recommendation was for expert to be used as an initial diagnostic test among presumptive TB cases. Use of expert as an initial diagnostic test for TB increased case finding by about 30%. The test was significantly more sensitive than sputum smear microscopy. The decision, however, of the CPG group to make this a weak recommendation for these situations was due to the substantially greater cost of using expert MTB RIF compared to microscopy. In the past few years, the Department of Health has embarked on the rollout of rapid TB testing utilizing the expert MTB RIF to detect TB and drug-resistant TB. From just 84 expert machines in 2014, there are now 488 expert machines distributed in various government TB treatment centers. The sixth and latest edition of the Manual of Procedures of the Department of Health National TB Program now states as a policy the use of expert MTB RIF assay as the primary diagnostic test for TB in the Philippines, replacing direct sputum smear microscopy. So for our 2020 TB CPG, it also now strongly recommends use of expert MTB RIF as the initial diagnostic test of choice for pulmonary TB. This recommendation was based on findings from 4 high-quality studies comparing the sensitivities and specificities of expert MTB RIF and direct sputum smear microscopy using TB culture as a reference standard. Expert MTB RIF had better sensitivity with a pooled estimate of 96% compared to DSSM at 54%. So this means that expert MTB-RIF identifies more true positive cases and less false positive cases of pulmonary tuberculosis compared to DSSM. Both expert MTB-RIF and DSSM had comparable specificities and had similar yields for true negative cases. To address the cost of expert in the private sector, the national platform to access concessional pricing through a consortium of private laboratories and hospitals has been established to be able to offer reduced uniform pricing to patients. The consortium was organized to ensure that quality diagnostic tests, including expert, are made available at concessional pricing to private laboratories and hospitals, and that these tests are available to the general public at affordable costs. Next slide, please. Okay, so the second diagnostic question is, among adults with presumptive pulmonary TB, how accurate is sputum TB lamp compared to expert in establishing initial diagnosis of pulmonary TB? And when is the sputum TB lamp a preferred test over expert MTB-RIF? Next slide. TB loop-mediated isothermal amplification assay, or TB-LAMP, is a WHO-approved rapid molecular test. TB-LAMP can detect MTB directly from sputum specimens. It is a manual assay that requires less than 1 hour to perform. The results for TB-LAMP can be read by the naked, Okay, I think that's the correct slide. So the results for TB lamp can be read by the naked eye or under ultraviolet light after 15 to 60 minutes. Since the assay does not require sophisticated instrumentation, it can be used at the peripheral health center level. The biosafety requirements of TB lamp are similar to sputum smear microscopy. TB lamp has only been recently available, so this test was not mentioned in the 2016 CPG. The sixth MOP policy statement on TB lamp is for this test to be used as an alternative diagnostic test if expert is not accessible, and that the unavailability of expert MTB-RIF shall not be a deterrent to diagnose TB disease bacteriologically. The 2020 CPG states that TB lamp is as accurate as expert in the diagnosis of pulmonary TB. A 2019 meta-analysis and systematic review, which included 13 studies with more than 5,000 participants, explored the diagnostic accuracy of TB lamp in the diagnosis of PTB. In this review, TB lamp appeared to be less sensitive than expert, but the difference in sensitivity was not statistically significant, and the specificities of the two tests were similar. Unlike expert MTB-RIF, TB lamp cannot detect rifampicin resistance. So for patients with positive TB lamp results, follow-on testing using rapid molecular tests that detect RIF resistance should still be done. For this reason, the consensus panel recommended that expert is still the recommended diagnostic test of choice for initial diagnosis of PTB. In a cost-effectiveness analysis, both expert and TB lamp improve case detection rates for TB. Since TB lamp requires simpler infrastructure, this is generally a cheaper and more affordable alternative molecular test to expert MTB-RIF. The 2020 CPG recommends that TB lamp may be used in areas where expert is unavailable and among individuals with low risk for drug-resistant TB. TB lamp, however, is not yet commercially available in the Philippines. Next slide, please. Okay. Thank you. The third diagnostic question is, among adults with presumptive pulmonary TB, should sputum TB culture with drug susceptibility testing be done with expert? Next slide. Okay, there. So in the 2016 CPG, it was mentioned that TB culture remains the gold standard for TB diagnosis. If available, sputum TB culture can be requested in the diagnostic workup of TB, specifically in ruling out NTM. The long turnaround time of results, limited access, and cost of cultures limits its routine use. TB culture should be performed preferably in quality assured culture centers recommended by the National TB Program. While rifampicin resistance is a possible indicator of MDR TB, expert MTBRIF does not eliminate the need for phenotypic DST in MDR-TB patients, since specific drugs still need to be tested. So the 6 MOP recommendation who are high risk for drug-resistant TB should submit 2 sputum samples for line probe assay for determination of second-line drug resistance and TB culture with phenotypic drug susceptibility testing. The tests here are done sequentially. So for the 2020 CPG, sputum culture with drug susceptibility testing is still recommended to detect resistance to other anti-TB drugs. When expert MTB-RIF shows rifampicin resistance, or rather, when expert MTB-RIF shows rifampicin resistance, and this is consistent with the 2016 CPG recommendations as well as the 6th MOP statements. We did not find any studies comparing expert MTB-RIF alone with expert MTB-RIF and sputum culture with DST. All studies encountered to date by our reviewers determined the accuracy of expert in detecting tuberculosis with sputum culture as the reference. There is no evidence for or against the utility of concurrent testing with expert MTB-RIF and sputum culture with DST in patients with presumptive TB versus expert alone. Okay, next slide, please. The fourth diagnostic question is, among adults clinically diagnosed with extrapulmonary TB or EPTB based on imaging studies, should further bacteriologic workup be done versus histopathology alone to establish the diagnosis of EPTB? Okay, next slide. The recommendation in the 2016 CPG is to pursue bacteriologic confirmation for patients suspected to have extrapulmonary TB through tissue or fluid direct microscopy, smear, TB culture, or expert MTB-RIF. There are patients who receive TB treatment based on histological and or clinical radiologic findings consistent with active TB. These patients are classified as clinically diagnosed EPTB. In the 6th MOP, it states that for presumptive EPTB cases, body fluid or biopsy samples that are appropriate for expert MTB-RIF testing shall be obtained. And in the 2020 CPG, it now reiterates the earlier 2016 CPG and 6 MOP recommendations for adults clinically diagnosed to have EPTB based on radiologic or imaging findings, to have bacteriologic workup in addition to histopathology. And this is a strong recommendation, but with low quality of evidence. A recently published systematic review and meta-analysis by Coley and colleagues determined the accuracy of expert compared with culture in individuals with presumptive extrapulmonary TB. Across the different types of specimens, pooled expert sensitivity versus culture varied from 31% in pleural tissue to 97% in bone or joint fluid, and more than 80% in urine, bone or joint fluid, and tissue samples. Pooled expert specificity versus culture had less variation, 82% for bone or joint tissue to more than 98% in CSF, pleural fluid, urine, and peritoneal fluid. Okay. Next slide, please. The fifth diagnostic question is, among adults whose bacteriologic workup for active TB is negative, how effective is empiric treatment based on physicians' clinical judgment in achieving treatment success and reducing relapse and mortality? There was no statement pertaining to this in the 2016 CPG. In the sixth MOP, there's no policy statement that directly answers the question. The policy statement there is to refer TB suspects with negative bacteriologic tests to health facility physicians who shall decide on the based on clinical diagnosis, the treatment to be given to the patient. And the patient can also be referred to the TB map. In the 2020 CPG, due to paucity of data, the panel did not find sufficient evidence for or against recommending empiric treatment based on physicians' clinical judgment among patients with negative bacteriologic tests, but with clinical signs and symptoms of TB. The panel recommends that characteristics of this patient must be further described, like, who are symptomatic, who are not responsive to antibiotics, to allow valid comparisons with participants used in other studies. So this question remains to be a key research gap. The panel, however, recommends empiric TB treatment in HIV-positive patients whose bacteriologic workup for TB is negative. This was based from one observational study among smear-negative PTB severely ill HIV patients. The study showed that patients who were empirically treated with anti-TB medications based on clinical decision had better outcomes based on mortality at 8 weeks after starting TB treatment, as compared to no treatment as a clinical decision. We had two other diagnostic questions pertaining to Expert Ultra. We are unable to present the CPG consensus statements and recommendations for these questions today, but we will do our best to include this in our final CPG. Thank you for listening. So may I now call on Jemmy. Thank you.
Okay, thank you, Ma'am Janice. So let me just request for remote control. So for the Committee on Treatment, as mentioned by Dr. Berba, we only prioritize the most pressing issues. So we only addressed a couple of questions for our part. So the first question is, among adults newly diagnosed to have rifampicin-susceptible pulmonary TB, is the standard 2 months of HRZE plus 4 months of HR still the recommended treatment regimen to optimize treatment success or completion and reduce risk for treatment failure, relapse, and mortality compared to HRZE plus fluoroquinolone. So when I say HRZE, I refer to the quadruple treatment of isoniazid, rifampicin, pyrazinamide, and ethambutol. And HR is for isoniazid and rifampicin. So we address the question on whether we need to add fluoroquinolone to our standard treatment for TB. So in the 2016 CPG, the recommended treatment for pulmonary TB and extrapulmonary TB newly diagnosed patients, except for those involving meninges, bones, and joints, is the 6-month regimen of 2 HRZE plus 4 HR. And we previously categorized this as category 1. So in the 6th edition of the Manual of Procedures, this is similar to what is labeled as Regimen 1. So for pulmonary TB and extrapulmonary TB, whether new or retreatment cases, with the expert result showing rifampicin sensitivity or rifampicin indeterminate, the 6-month regimen of 2 HRZE plus 4 HR is recommended. For new cases of pulmonary TB or EPTB, except CNS, bones, and joints with positive TB lamp or sputum microscopy, or those who are clinically diagnosed where expert MTBRIF is not done or not detected, and there is a decision to treat, we still the MOP still recommends the 6-month treatment regimen. Now, in the 2020 CPG, the recommendation is among adults newly diagnosed to have rifampicin susceptible pulmonary tuberculosis, 2 months of HRZE followed by 4 months of HR is still the recommended treatment regimen. And this is a strong recommendation with high quality of evidence. And the inclusion of fluoroquinolone to the standard regimen is not recommended. Okay, so the recommendation is based on a high level of evidence uh, comparing fluoroquinolone-containing regimens versus the standard 2 HRZE and 4 HR based on outcomes of treatment failure, serious adverse events, and all-cause mortality. So the fluoroquinolone-containing regimens did not show superiority over these clinically important outcomes. And this evidence is based on a network meta-analysis of 12 randomized controlled trials involving more than 6,000 newly diagnosed sputum-positive adult patients. So there were no differences in terms of treatment failure. There is also no difference in all-cause mortality, both by the end of treatment and during the intensive phase of treatment. And in terms of adverse events, there was also no statistical difference. However, what was seen was that compared to the HRZE regimen alone, moxifloxacin-containing regimens could significantly increase sputum conversion for patients with newly diagnosed pulmonary tuberculosis. So this just shows our summary of evidence showing that apart from sputum conversion, the other clinically important outcomes such as treatment failure, all-cause mortality by the end of treatment and during intensive phase, and serious adverse events did not differ significantly between HRZE and the fluoroquinolone-containing regimens. The next question is, among adults who need retreatment for tuberculosis with known susceptibility to rifampicin by expert testing, is the standard 2 HRZE followed by 4 HR the recommended regimen to optimize treatment success or completion and reduce risk for treatment failure, relapse, and mortality compared to what was previously recommended as the Category 2 regimen of 2 months of HRZES followed by 1 month of HRZE followed by 5 months of HRE or immediate referral to a PMDT. So going back to the 2016 recommendation, it states that all retreatment cases should immediately be referred to the nearest expert MTB-RIF facility for rifampicin susceptible testing. And Category 2 regimen of the 8 months of total treatment should only be given among confirmed rifampicin-sensitive retreatment cases or in circumstances where expert MTB services cannot be performed. And rifampicin-resistant cases should be immediately referred to a PMDT facility for further management. Now, looking at the 6th edition of the Manual of Procedures, what is recommended is Regimen 1, or 2 months of HRZE followed by 4 months of HR. And this is recommended for PTB or EPTB retreatment cases, except those involving the CNS, bones, or joints, with the final expert MTB result of RIF susceptibility or RIF sensitive and RIF indeterminate. And this recommendation is based on the now widely available expert MTB RIF testing. Now, looking at the 2020 CPG, in patients who require TB retreatment with confirmed rifampicin susceptibility by rapid drug susceptibility testing, the Category 2 regimen that includes streptomycin should no longer be recommended or is no longer prescribed. On the basis of rapid drug susceptibility testing to rifampicin, a standard first-line treatment regimen of 2 months of HRZE followed by 4 months of HR is recommended. And revisions in the drug regimen shall be made based on the results of the full drug susceptibility testing. If rifampicin resistance is present, the patient should be referred to a facility specialized in the care of drug-resistant TB. But you will see that this recommendation is a good practice statement that we based on the WHO 2017 recommendation. And why was this so? Because in our literature search, there were no RCTs comparing HRZE versus HRZES or immediate referral to a PMDT for retreatment cases. So the WHO guidelines for treatment of drug-susceptible tuberculosis and patient care was adapted to answer this question. So going back to the table, our 2020 recommendation supersedes the previous 2016 recommendation on Category 2 treatment regimen for retreatment cases. So this is an update to the 2016 version of the guidelines regarding treatment of retreatment cases. And therefore, rapid drug susceptibility testing for drugs other than rifampicin should be done to inform the choice of treatment. However, if rapid drug susceptibility testing is not readily available, then in such cases, the physicians are advised to start Category 1 empiric treatment regimen while waiting for the results of the rapid drug susceptibility test or the full drug susceptibility testing. So the good practice statement from the 2017 WHO guidelines was based on a systematic review of 20 studies on clinical outcomes of Category 2 empiric treatment regimen. So what they found out in this review is that the median treatment success rate was only 68%. So this is for the Category 2 treatment. And this was way below the WHO target of 85% treatment success rate. Furthermore, the use of streptomycin further increased adverse events such as ototoxicity and nephrotoxicity. And the addition of a single drug to a previously ineffective regimen of HRZE also did not improve treatment success rate. So a grade recommendation could not be formulated based on this evidence Hence, the WHO Guideline Development Group drafted a good practice statement, which we adapted for our local CPG. A more recent systematic review of 39 studies by Cohen et al. Also further supported the WHO recommendation. In this review, they looked at treatment success rates of Category 2 treatment, and the treatment success rates range from 27 to 92%. However, only 2 out of the 39 studies met the WHO target of 85% treatment success rate. The success rate was less than 75% in 29 studies and less than 50% in 4 studies. So because of these low rates of treatment success in majority of the studies, this supports that we do not favor the category 2 treatment regimen anymore for retreatment cases. So that is my last slide. I will turn over the floor again to Dr. Balanag for the open forum.
Naka-mute pa siya. Vince.
There are some questions already in the chat box. This is Janice. Is Dr. Balanag here already?
Maybe we can start it.
Okay, perfect. So I think some questions were already answered by the first question, however, is about PhilHealth. And I know this question has not yet been answered live. So the first question is, one of the challenges in implementing the use of expert MTB-RIF as initial diagnostic test is the cost. So is it possible to forward this recommendation to the national government for proper PhilHealth budget allocation? So can I ask someone from the panel to answer this? I know that this has already been discussed with PhilHealth, but I cannot really say for sure, if it will be included. So Lelaine?
Janice, I can take over. So for the question about
Yes,
the PhilHealth,
sure.
currently the package is being reviewed, being revisited, and the diagnostic workup might be included, but for finality, this will still be out. So it's still in discussion. But definitely, we have access to free gene expert in government facilities, and we already have private laboratories and hospitals already offering concessional pricing. Back to you, Janice.
Okay.
Yeah,
Hi, Doc.
thank you for taking over. So we have another question here from Mark Caro. Is giving of rifampicin among symptomatic sputum AFP negative, chest X-ray negative? Um, I missed it.
I think it was transferred.
Dr. Blair typed an answer.
Yeah, it was answered already.
So is it still given for HIV positive cases? I think that's the question. Is
Marcel
Claire
answered
already
it.
there?
Yeah.
She'll be speaking a little later. Maybe we can get that answer later on. Is hemoptysis or blood streaked sputum a contraindication to do sputum smear and gene expert? Because medical technologies are rejecting them because of the blood. So what's the advice you can give for these cases?
Yeah, so the
Anybody?
laboratories, thank you, Doc. Our labs, our TB labs usually require that specimens should not have a fresh blood or even blood particles or food particles. So we usually wait until the patient has, a better sputum quality, because I think there are inhibitors in the blood that can affect the results of expert.
Yeah,
Back to you,
regarding
Doc.
treat. Yeah. So some of these are comments. Thank you for sharing your expertise. Well, another one is, are TB PCRs using tissue for extrapulmonary TB covered by the government TB program, and hence are they free?
I know, Doc, that in some centers, like Lung Center of the Philippines and even Tropical Disease Foundation, they already accept specimens from extrapulmonary sites. So I suggest that you coordinate with your expert centers, no? If you have specimens for testing.
Um, I have a question. Since category 2 is no longer recommended, so will streptomycin still be available under the program, or will this be scarce already for any possible use? Can
So
anybody answer?
yeah, I think, Doc, in some of the health centers, they don't have streptomycin anymore. And this is based on our programmatic treatment, where we do not recommend using streptomycin for retreatment cases. So instead, they should do a rapid drug susceptibility testing, and they should taper the treatment. If the patient is rifampicin susceptible, then we can use the 6 months of treatment. If the patient is rifampicin resistant, then we can refer already for treatment of MDR-TB.
Because I know the trend now is shying away from the injectable. So maybe will really be a time wherein streptomycin will no longer be available. Yeah, I think we still have one more question. Do you still need to treat asymptomatic? Well, this will probably be answered later on regarding latent TB. And is it still required to have both X-ray and BSSM prior to requesting expert? So what would be the answer for that?
Okay. Is that for me, Doc? I
Yeah,
was answering
anybody
another.
can answer, yes.
I'm
So
sorry. Can you? But which question was that?
do you need to do the X-ray and sputum before you request for a gene expert?
No, you can go directly to expert.
Yeah. So,
It's recommended.
I think if you have more questions on the diagnosis, treatment, and screening, you can just type in those questions. We have to go to the next part for lack of time. So let me go to our next part, the part two, and have our slides for the speakers for the next four presentation. May I have the slides? Okay, thank you. So our next four speakers are, the first one would be Dr. Jubert Benedicto. Oh, sorry. So Jubert Benedicto, he is the Standards and Private Provider Specialist of PTSI as a subgrant of the USAID. Steering Committee representing PCCP for the 2019 CPG for Adult TB. Past National Health Chair, PhilCAT. And awards are 2014 Most Outstanding Fellow in Research, as well as 2015 Outstanding Public Servant. He's currently the head of the Public Health and Domiciliary Unit TB-related services of the Lung Center of the Philippines, and head of the DOTS Clinic of San Juan de Dios Hospital. Next, we have Dr. Maria Tarcela Glaire. She is a board member, PSMID, training officer, Section of Infectious Diseases, Makati Medical Center. Is also antimicrobial stewardship head of the same institution. She is clinical research coordinator for De La Salle Medical Health Science Institute, TB Research Center, and a consultant of the National TB MDR-TB Consilium. She will be followed by Dr. Evelyn A. Rojas. She is Associate Professor 2, Department of Medical Microbiology, College of Public Health of UP Manila, Clinical Associate Professor, Division of Infectious Diseases at UPPGH, President of the Philippine Hospital Infection Control Society, Gender Focal Point Person, the College of Public Health, UP Manila, Chair of the MPH DTTB Batch 2 Committee of UP Manila College of Public Health. Is an infectious disease consultant of Manila Med and UPPGH, Head Section of Infectious Diseases, Department of Medicine, Manila Med, and Vice Chair of Infection Control Committee and AMS Committee of the same institution. And last but not certainly the least, Dr. Lalaine Mortera. She's Deputy Head to the Assembly Asia Pacific Society of Respirology, past National Chair, Philippine Coalition Against Tuberculosis, TB Advisory Council of PTSI. She's Associate Clinical Professor, MCU College of Medicine. She's an active pulmonology consultant in major medical centers in Metro Manila, including MCU and other Pacific Global, Metro North Hospital Medical Center. So we go straight to the presentation of Dr. Jubert Benedicto on latent TB infection. You have the floor, Jubert.
Thank you very much, Dr. Balanag, for that kind introduction. And I'm quite honored to be part of this committee that will be cascading for the first time, as what Nina pointed out, during this PSMID convention. So my main task is on behalf of the Latent TB Infection Committee to give you the highlights, what we did as far as specifically issues concerning LTBI. Let me start off by saying that, of course, LTBI is one of the most not frequently visited area of particular consensus, maybe because as far as LTBI is concerned, not everyone has really digested and really sit on and appreciated the concept behind LTBI. But definitely we have to grapple with it because as what was mentioned in the introduction, we have in fact some key targets that we hope to accomplish in terms of screening for LTBI and in terms of putting these persons appropriately to be on medications specifically targeting latent tuberculosis. So the first question that the committee addressed is, should non-HIV adult household or close contact of active TB, regardless of bacteriologic status, so we're talking about clinically diagnosed or bacteriologically confirmed, with no active disease, undergo screening, basically using interferon gamma release assay or IGRA, or tuberculin skin test or TST to identify latent TB. So we are really asking ourselves, we were asking the issue, is it worth it to really look at LTBI among this close contact? And a corollary question, is IGRA more accurate than the standard TST? So basically, as far as the recommendation of IGRA versus TST, our recommendation is that either a tuberculin skin test or IGRA may be used to screen for latent TB infection among non-HIV close contact of patients with active TB. It's always an issue of cost, the availability of these tests, and the need for other resources. Of course, we're talking about practicality sometimes. Yung mga health worker nyo ba, let's say, trained in terms of interpreting TST, or will it be more practical for the patient? These are all have to be considered when deciding on which test to use. From the uh, recommendations from other guidelines, specifically from the Philippine TB Guidelines 2016, it was still TST as the preferred screening test for LTBI, but this was emphasized during that time, and it was a healthy debate that we are a resource limited setting. And therefore, it was strongly recommended, despite low quality of evidence, that TST is really the preferred route to go in terms of screening for possible LTBI. But I would say, of course, that has evolved already, considering that IGRA is available and it may be subject to, less deviations in terms of interpretation. For one of the landmark documents that we use as reference, WHO, the LTBI guidelines for 2018, has this statement as far as this particular subject. Either, again, TST or IGRA can be used to detect for LTBI. Again, there was low quality level of evidence but strong recommendation. Remember, these particular guidelines were really crafted based or anchored on programmatic settings, the MOP and then the WHO TB-LTBI guidelines. Having said that, if you're going to look at the sixth edition of the Manual of Procedures, they do have this algorithm which the framers from DOH, in fact, was telling us is really not much implemented to their surprise. So they were looking at, let's say, HIV negative contacts, pediatric age group, less than 5 years of age. You can see that it is really primordial for us to look for symptoms that may suggest active TB, and then look at if the symptoms is there for how many days already. And then you are also being encouraged to look at and monitor the persistence of symptoms. If in any part you are saying that you think that that particular child has active TB or possible presumptive TB, then of course you should be working up that particular child. But remember, you should be monitor if the symptoms resolve or if the child is well. And as you can see, X-ray was not required to give preventive treatment. DOH has been emphasizing this because during their implementation, majority of the time, they did see certain subjects that had to be screened for LTBI or have to be given LTBI treatment. However, dahil nandun yung notion na kailangan pang pa-X-ray yung child, hindi nagawa. But looking at this particular algorithm, you can see that it is really just anchored on the symptom of the patient and, of course, the exposure that that particular child had. As you can see, if the household contact is clinically diagnosed, TB, you perform TST. This is for clinically diagnosed TB. And if it's negative or TST was not available, just monitor this patient, especially for the symptom. If it's positive, then you give preventive treatment. For HIV negative at-risk individuals more than 5 years of age or at least 5 years of age, you can see that again, we are being encouraged to possibly screen for active TB. In this particular subset, in this particular group, you may look at X-ray because they are more available more often than not. And then look at the possibility of doing TST. Again, this is for at least 5 years of age. And depending on the results of the TST, you are being now encouraged, if it's positive, to treat for LTBI. If that particular individual has no symptom, X-ray possibly was not yet done, then do a TST again. And then depending on the result, you can very well go down the algorithm. So as you can see, the anchoring foundation of this algorithm is really trying to rule out possible active TB along the steps. And if you are comfortable subsequently. So you can see just this table summarizing, of course, the sensitivity between TST and IGRA using the various uh, sizes. And as you can see, it really tends to vary depending on the population. And therefore, you can appreciate the above recommendation. The last question that we address is how about the treatment for latent TB among non-HIV adults? Do we still use the 9 months of isoniazid, 6 months of isoniazid, 3 months, 3 to 4 months of isoniazid plus rifampicin, or we do know that there's already rifapentin, possibly by second quarter of next year, with isoniazid just requiring 12 doses once a week versus no treatment. And remember that your main aim at this point was to possibly lessen the risk of that infection turning to an active disease. So as far as the recommendation is concerned, isoniazid given once daily for 6 months is still recommended, can still be recommended for treatment of latent TB among non-HIV adult patients, so strongly recommended. Rifampicin given once daily for 4 months, so you can see that rifampicin-based regimen tends to shorten the LTBI treatment, can be considered as alternative treatment for latent TB. And then we came out with this last bullet, rifapentin plus isoniazid 12 doses weekly. During this particular consensus algorithm, not much rifapentin studies came out because they came out more early part this year. And therefore, I would say that those were not considered when we crafted the last bullet, but the signal is there. Okay, if you're going to compare it as far as the previous guidelines are concerned from the previous CPG 2016, yes, isoniazid was recommended. Even WHO recommended that 6 months isoniazid alone, and then the possibility of, again, rifapentin plus isoniazid as an alternative to the 6 months of isoniazid. So you can see that if we're going to go through all the treatment regimen, definitely having treatment for LTBI is better compared to placebo. So there are various WHO recommended treatment from their landmark document that I've mentioned. So our consensus is quite consistent with that of WHO as well. So with that, I'm going to turn the floor to Dr. Maria Tarcel Aguilar.
Good afternoon, everyone. Thank you, Jubert. So, I am just trying to. Wait. So for MDRT for the MDR-TB section, just for the understanding of everybody, MDR-TB or multi-drug resistant TB is defined as an isolate which has resistance to both INH and rifampicin. And for this section, we've lumped MDR-TB and rifampicin resistance TB because the gene expert only detects rifampicin resistance. So somehow for patients who have rifampicin resistance by gene expert, we treat them as an MDR-TB case. So during the time that we were making the questions for this section, we had an important data. There was an important data on treatment for multi-drug resistant TB, which was the standard shortened treatment regimen. So we focused on this question. So the question 12 is among persons with multi-drug resistant TB or rifampicin resistant TB, is the standard shortened treatment regimen as effective as the WHO conventional multi-drug or rifampicin resistant regimen. So the conventional would be the longer regimen. Standard regimen, standard shortened is 9 months, and the conventional regimen is 12 to 18 months. So next slide, please. Can you just control it for me? So in the 2016 CPG, we had several questions for this section, which was separated into screening, diagnosis, and management. And for this consensus update, the screening diagnosis questions were consolidated in each of their respective sections. So for this section, we focus on the management. Next slide, please. So the 2016 CPG recommendation, the question 3 was how should DRTB be managed? Our statement was all DRTB patients should be managed under the programmatic setting, and management of DRTB involves the use of second line drugs that are more expensive, less effective, and more toxic for at least 18 months. This is the conventional regimen, though a lot have changed from the time that we have written this 2016 recommendation, because there were three new drugs that was approved for MDR-TB. And immediate referral to the nearest PMDT treatment center or satellite treatment center is mandatory. We still recommend, for the 2020 CPG recommendation update, we still recommend that all patients with RRTB or MDR-TB be referred to the nearest MDR-TB clinic for initiation of appropriate MDR-TB regimen. But we added a statement that if the clinician desires or if the clinician wishes, they can present the patient's case, their case, to the regional TB Medical Advisory Committee, or what we call TB-MAC, whenever applicable during their regular meeting. This is a best practice statement because in the survey of the WHO regarding involvement of private clinicians to for MDR-TB management, there was a strong desire of clinicians, of private clinicians, to be involved in MDR-TB for continuation of care. So we added this statement with the permission of the NTP. Next slide, please. So referral to the National TB MAC would be as follows. They have forms. This would be made available probably if this will be operationalized, the referral system. So if you would like to refer your patient to the national or regional TB MAC or Management Advisory Concilium Committee, you need to enter the relevant data, the treatment history, DSTs, cultures, using their treatment enrollment case and case management form. And this form should be emailed to the TB MAC chair, and the TB MAC chair will contact you for queries regarding the case through email also. And the decision of the TB MAC will be relayed to the PMDT clinic or to the private clinician if this will be operationalized within 24 to 48 hours from the time that you have emailed them. So this is the list of the medical advisory committees in several areas. So I've also placed the emails here for easy access to them. Okay. So just to compare our CPG statement and to the WHO guidelines, as well as to the manual of procedures by the National TB Program, published in 2020. So our statement, the panel recommends that the shortened regimen of moxifloxacin, clofazimine, ethambutol, pyrazinamide in 40 weeks, supplemented by kanamycin, isoniazid, prothionamide in the first 16 weeks among MDR and RR pulmonary TB may be recommended. And this was a conditional recommendation, although the quality of evidence was moderate. So this statement is based on the STREAM trial, or the standard treatment regimen of anti-TB drugs for patients for MDR-TB, which was an open label, randomized, multicenter, international, parallel, non-inferiority trial involving 424 adults with rifampicin-resistant pulmonary TB, which evaluated the effectiveness of a 40-week regimen, the standard regimen, over an 80-week conventional WHO regimen. So the result shows that a short regimen of 9 to 11 months did not significantly differ from a long duration regimen of 20 to 24 months in terms of attainment of favorable outcomes. And there were no difference also in serious adverse events. So the 2020 consolidated WHO guideline, though, we had a conditional recommendation for this because there were a lot of there were already evidences that came out that the injectable agents had more adverse events. So there was a call for an all-oral regimen, and the 2020 consolidated WHO guideline has recommended an all-oral bedaquiline-containing regimen for 9 to 12 months. So this would replace the kanamycin in the standard short course regimen. And but they should only be given to patients who have not been given second-line treatment for more than 1 month, and in whom resistance to fluoroquinolone has been excluded. So this is also a conditional recommendation because the evidences for this are based on cohort data and the South African operations programmatic data, where they replaced the injectable agents in the short course regimen with bedaquiline. So our manual of procedures has recommended also an all-oral regimen, and we have actually been implementing the all-oral regimen, especially during the time of the pandemic. So next slide, please. So I was tasked to also do the TB HIV section, and we had 2 questions for this part, but we are only able to disseminate one of the questions. So among HIV patients on lopinavir, ritonavir, and are receiving rifampicin-based regimen for TB co-infection, should the dose of ART, lopinavir, ritonavir, be increased or boosted or doubled to reduce virologic failure and adverse events? So in the 2016 CPG guideline, there were 3 questions also for the TB HIV section pertaining to screening, diagnosis, and management. And for this consensus update, we will only focus for this section the management aspect, because the screening and diagnosis has already been consolidated in each of the sections. Next. So for this in answer to the guideline question, amongst HIV patients with TB co-infection who are rifampicin on rifampicin-based regimen, Caution should be exercised to increasing the dose of lopinavir, ritonavir. Increasing the dose may increase the risk of adverse events without reducing virologic failure. So this is a weak recommendation with very low quality of evidence, and I'll show the reason in the next slide. So this would be the evidence, each basically based on 3 cohort studies, which are of small sample sizes for a total of an 81 sample size. So for virologic failure, in one of the studies, boosted versus non-boosted was, I also showed here the sample sizes so that you will see that the very low sample sizes for the first part, 23 versus 33 cases, patients. So there was no significant difference in the virologic failure, in terms of virologic failure for those patients who are on rifampicin versus the in amongst those given on boosted versus non-boosted dose. And the other one was there was also, it was 16 versus 22 cases, and for adverse events there was a significant difference in adverse events amongst those cases who were on boosted or increased dosing. And now I will turn over the floor to Eva, who will be doing the TB prevention.
Thank you very much, Dr. Glare. So on behalf of the TB Prevention and Infection Control Group, I'll be presenting our output. So it's my honor to be with this powerhouse lineup of all the members of the TWG. So actually for this group, we only answered one question. So the question is, among high risk or special settings, what are the recommended measures to prevent transmission of TB? Next slide, please, Joanne. So the group searched for guidelines specific to yielded hello?
We can hear you.
Hello, can you hear me?
Yes,
Okay
we
na
can
kaya?
hear you.
Okay na.
Okay, so sorry for that. So the group searched for guidelines on the TB prevention, infection control, and were able to search the CDC guidelines in 2005 and the WHO guidelines in TB prevention, infection control in 2019. So we did critical group appraisal of the 2 guidelines using the appraisal of guidelines, research, and evaluation, or the agreed to instrument. And the overall assessment using this agree instrument yielded scores of 83% for the WHO 2019 guidelines and 50% for the CDC 2005 guidelines. Next slide, please. So we did current survey since the end of the search date of the WHO guidelines in 2018, and there were no additional pertinent studies. And both the CDC 2005 and the WHO 2019 TB infection and prevention control guidelines mentioned the following: administrative controls, environmental controls, and respiratory protections as the effective measures to prevent the transmission of the bacteria. Next slide, please. Because of this, our main reference, back please, our main reference was the WHO 2019 guidelines on TB infection prevention and control. Next slide, please. So we had 7 recommendations divided into administrative controls, engineering controls, and respiratory protection. So 4 under administrative controls, two recommendations under the engineering controls, and one recommendation under respiratory protection. So recommendation 1 states that triage of people with TB signs and symptoms or with TB disease is recommended to reduce MTB transmission to health workers, including community health workers, persons attending to healthcare facilities, or other persons in settings with high risk of transmission. Recommendation 2 states that respiratory separation or isolation of people with presumed or demonstrated infectious TB is recommended to reduce the transmission of MTB to health workers or other persons attending healthcare facilities. So both were given conditional recommendations based on very low certainty in the estimates of effects. Next slide, please. Recommendation 3 states that prompt initiation of effective TB treatment of people with TB disease is recommended to reduce transmission of MTB to health workers, persons attending healthcare facilities, or other persons in settings with high-risk transmission. So we gave strong recommendation for this statement based on very low certainty in the estimates of effects. Recommendation 4 states that respiratory hygiene, including cough etiquette in people with presumed or confirmed TB, is recommended to reduce the transmission of MTB to health workers, persons attending healthcare facilities, or other persons in settings with a high risk of transmission. So again, we gave strong recommendation, but based on low certainty in the estimates of effects. Next slide, please. So recommendations 5 and 6 were both under the environmental controls, and recommendation 5 states that upper room germicidal ultraviolet or GUV systems are recommended to reduce MTB transmission to health workers, persons attending healthcare facilities, or other persons in settings with a high risk of transmission. So we gave conditional recommendation based on moderate certainty in the estimates of effect. Recommendation 6 states that ventilation systems, including natural, mixed mode, mechanical ventilation, and recirculated air through high-efficiency particulate air or HEPA filters, are recommended to reduce MTB transmission to health workers, persons attending healthcare facilities, or other persons in settings with high risk of transmission. So again, this is a conditional recommendation based on very low certainty in the estimates of effect. Lastly, recommendation 7 pertains to the particulate respirators. So particulate respirators within the framework of a respiratory protection program are recommended to reduce MTB transmission to health workers, persons attending healthcare facilities, or other persons in settings with a high risk of transmission. So we also added that N95 masks may be recommended considering the high TB burden in the country, but cost and treatment setting must be considered. So this was given conditional recommendation based on very low certainty in the estimates of effects. Next slide, please. So take note that the panel unanimously agreed to adapt the recommendations from the 2019 WHO guidelines on TB infection prevention and control with 13/13 votes. So now comparing the 2020 CPG with that of the 2016 CPG on TB CPG, actually in the 2016 TB CPG, there was no separate section on TB infection prevention and control. So, and I would like to thank Dr. Nina Berba for suggesting that this 2020 TB CPG update will have a separate section on TB infection prevention and control. Nevertheless, in the 2016 CPG, there were IPC statements, but interspersed on different sections. For example, there was a question in the 2016 CPG which asked when should isolation be recommended. So somehow since we adopted the WHO guidelines, so we somehow included this in recommendation 1 and recommendation 2 of the 2020 CPG. Next slide, please. The question on what infection control measures must be observed in healthcare facilities was also included in recommendation 2 of the 2020 CPG. Next slide. In the 2016 CPG, it was not mentioned that prompt initiation of TB treatment was actually considered as a means of decreasing the risk of transmission of MTB. So we added this in the 2020 CPG. Next slide, please. In the 2016 CPG, there was a question, what will the observance of proper cough etiquette help minimize transmission of PTB? So this was actually included in the WHO guidelines under recommendation 4. So we still adopted it in the 2020 CPG. So we mentioned that respiratory hygiene is an effective measure to prevent transmission of MTB. Next slide, please. So there was also a question in the 2016 CPG, what infection control measures must be observed when handling TB specimens? So there were a lot of answers, but somehow we summarized it under recommendation 5. Next slide, please. There was no mention about ventilation in 2016 CPG. However, we included this in the 2020 CPG. So it was included under the environmental control recommendation. So lastly, for recommendation 7, so actually there was a specific question on the 2016 CPG, will the use of face masks prevent the transmission of MTB? So this was summarized in recommendation 7, talking about the particulate respirators. Next slide, please. I think this is my last slide with our selected references. Next slide, please. So that's all for the TB infection and prevention and control. So let us call on now Dr. Lalaine for TB notification. Thank you.
Good afternoon, everybody. I will be talking about TB notification. We actually did not look for evidence already because this is something mandatory. And after we learn about diagnosing, about treating, about this is now the best time to notify our patients. Okay. So I came across this article published in the ERS journal in 2014, which actually involves 15 high TB burden countries. And in this case, there are only 4 countries who did not have mandatory notification, and only 2 countries among the 4 had manual way of reporting. And it actually included the Philippines. So we were not able to contribute any data in this series of notification practices. We all know that in 2016, the mandatory notification was issued, and the year after, we had the IRR that was issued. And last year, during the Asia Pacific Regional Conference in April, Secretary Duque actually mentioned about 3 business not as usual strategies. Of course, in order to end TB, we have to address social determinants of health that would involve TB care, access for faster and better access to latest technology, and we actually need to enforce mandatory notification as a requirement. So in 2018, we were glad that the professional organizations actually convened and rallied against this NTB, rallied to support the NTB strategy, specifically to support the TB notification. And that this followed actually the awareness for the different platforms for mandatory TB notification. During the time, it was only the paper-based that was available. And after that, web-based platform for notification was made available. And recently, the mobile app using the iOS and the Android version was launched for our private physicians to be able to use. But all these platforms require that the physician need to register in the DOH Integrated TB Information System website. You have a link here, especially for those who haven't registered, in order to be able to notify. And don't forget to click the private notifier classification. So these are the different approaches to mandatory TB notification. In 2018, the local government unit actually deployed notification officers to collect paper-based notification forms from doctors. The year after, there was a support to hospital system strengthening, such that a hospital point person or TB clinic nurse is actually mentored and trained to be able to encode on behalf of the doctors the TB notification. And recently, of course, we have the digital tools that are made available to us. So this is the process of notifying. Previously, the only way to notify is to refer to a TB clinic to confirm the diagnosis and to start treatment. But now we know that doctors are also able to diagnose and start treatment as long as they undergo the relevant training, or still prefer to refer to TB clinics for initiation of treatment. But anyhow, these patients should still be notified through the attending physician through the mandatory notification IT slide. So this is the way for us to really capture patients even if they are privately managed. And this system can be supported where all the service areas in the hospital actually can be part of the system where they share information to a central notifying unit. At this point, we only will be able to do this if there will be some hospital-wide orientation when we actually train a focal committee to be able to undertake all these TB notification activities in the hospital. And the difference between individual approach, which was done in 2018, comparing that with the current approach when you involve the hospital management in terms of notification activities, we actually improve the ratio of the physician to the notified TB case from 1 is to 4 to as high as 1 is to 33. Um, if we look at the 2020 Global TB report released by the WHO, we actually have the highest notification from the public-private mix. So Philippines actually has one of the highest contribution among the 7 high-burden TB countries. But behind this high notification, there are actually certain challenges. One is the quality of TB notification. We know that there is very low bacteriologic confirmation among our patients. It's only at 3%. Most of the patients notified by doctors are actually clinically diagnosed. And worse, there was no reporting of the treatment outcome. As seen here in our graph, there is about 9% to 14% contribution through the mandatory notification, but the treatment outcome has not been reported. And this, in effect, actually reduced the overall success rate of our program, where from 91%, we actually went down to 83% and 84% for our treatment success rate. During the pandemic, this is also one of the challenges, how to notify during the pandemic. And you can see in the graph, based on some data culled from the IT's report for the last 3 quarters, we see a significant decline during the quarter 2 and quarter 3. And this is also reflected in the WHO 2020 report, where we see a significant steep decline comparing to the monthly cases reported if we compare that to the a proportion of January data. So another challenge is the limited awareness among physicians and health facilities about the requirement of TB notification. So we actually developed this video. It can be accessed in the website of the National TB Program. You can also download this and open source in YouTube. And this is to emphasize that notification happens not only upon diagnosis, but also upon treatment initiation and during treatment outcome knowledge. There are several materials already that have been developed to support physicians about the processes of notification. Probably these are one of the suggestions where we include in the reminder when we release the official X-ray reading suggestive of TB, not only to proceed to bacteriologic confirmation, but to also not to forget to notify if this would be an active TB case. Same is true with the official laboratory result. We would recommend that if treatment will be initiated, then this will need to be notified to the DOH as part of the mandatory notification. There's also a perceived data privacy issue with TB notification. And this was addressed when the Department of Health actually wrote to the National Privacy Commission to get a legal opinion on this. And they actually said that the DPA, or the Data Privacy Act, should not be able to be used in order to curtail the sharing of information, as long as it is done with the observance of the principles of data privacy. And with this, there were patient materials that were shared, and you can see the link if you would like to have access to this material. For the IT's mobile app, these are the security features. The mobile phone can be blacklisted when it gets lost. There is an auto log out when you actually notify using the app, and password protected feature, including encryption of data. Notification processes are also perceived to be time consuming, but hopefully with the notification app, we'll be able to do notification as simple as 1, 2, 3. And these are the key features of the notification app. We can easily notify even offline, and this can sync automatically with the data on the web base. You can track treatment outcome, you can add or edit notification, and it will also ensure security of the patient data. For doctors who do not see patients for the month, it can also allow zero reporting. However, this feature is limited to the doctor only and not to the encoder. So these are other functionalities. You have a dashboard, you'll be able to know how many notified cases you have been contributing in order to end TB in the Philippines. So at this point, these are what is in the pipeline for TB notification. The program, National TB Program, is looking at laboratories being able to notify as well. Latent TB infection as part of the notified cases. Would it be as part of a requirement for claims processing? And also a balance between sanctions versus incentives, or included as part of licensing for hospitals. Also, integration in electronic medical records, especially during the COVID pandemic, when most doctors actually go to telehealth platforms. So I think this is my last slide. Back to you, Dr. Vince, for the open forum.
So maybe we can start already answering the floor for the open question for the questions that that were posted in the Q&A while waiting for Dr. Vince.
Yeah, okay.
Yeah.
So one of the questions here posed by our audience is, what would be the preventive treatment for household contacts of MDR-TB?
Would you like me to answer that?
Yes, Maricel.
Okay. So there are no evidence yet as to the specific intervention for household contacts of MDR-TB. Several studies are being done regarding this. Levofloxacin is being used. I'm actually involved in a clinical trial where we are testing the Delamanid, one of the new drugs for MDR-TB, for household contacts of MDR-TB. This is a big trial done globally, sponsored by the US NIH, and it involves contacts, the index. We approach the index of MDR-TB patients and randomize them, clustered randomized trial comparing INH versus Delamanid. So that is one of the trials. There are a lot of other trials using levofloxacin, but as to date, there's no recommendation. We cannot recommend a specific treatment yet for household contacts of MDR-TB.
And there's another question on LTBI. Would using a rifampicin-based LTBI regimen encourage development of more rifampicin resistance? Jubert?
Yeah. Yes. I think I've answered that. That's from Fee. So we did not encounter encountering resistance if you're going to use it in an LTBI framework, because the main dictum, as what we have emphasized, is to really rule out possible active TB before you embark these patients on an LTBI regimen.
So we have a lot of questions, but I think we have run out of time. So let me give a short summary before we end our session. Of course, we'd like to congratulate all the speakers for their very informative presentation, giving all the information in such a short time. The overall impression here is the CPG for 2020 is very much responsive to the call for greater effort against TB called by the WHO and the national government. And I'm quite happy about the new recommendations, particularly the greater role of chest X-ray, the tuberculin skin test, and of course category 1 treatment. There is a greater willingness to embrace the technology, kasi before the previous CPGs there was concern for cost or availability, but I think the new CPG is more willing to consider greater efforts despite the cost to
Hello, everyone. Oh, there. Okay. We had a technical glitch again. So, Dr. Vince, carry on.
Sir, Dr. Balanag, you're on mute po.
Vince, nakamute ka. Vince, nakamute ka. Vince.
Okay. Can you hear me?
Yes.
Yeah. So, as I've said, this is a CPG is very much responsive to the call for greater efforts in finding the TB cases and having them treated. So, with that, we'd like to extend our thanks for all the speakers and all those who joined us in this session. So we go ahead with the awarding of the certificates to our resource speakers. So the certificate of appreciation is given to Jubert Benedicto MD for his participation in this session. Congratulations, Dr. Jubert. And the same certificate of appreciation is given to Dr. Nina Berba. Thank you very much, Nina. And as well, this certificate of appreciation is given to Janice Kawili MD. Thank you and congratulations, Janice.
Thank you.
The same certificate of appreciation is given to Dr. Gemeline Yu Garcia. Thank you very much, Gemeline, for your participation. We're giving this certificate of appreciation also to Dr. Maria Tarcela Glaire for her participation in this CPG TB in Adults 2020 update. Thank you very much, Dr. Maricel. And this certificate of appreciation is given to Lalaine Mortera for her participation in the session on the 2020 CPG update. Thank you very much to all the speakers. And of course, to the Dr. Mario Panaligan for his participation in this presentation of the clinical practice guidelines in adults 2020 updates. Thank you very much, Dr. Mario. And the same certificate of appreciation is awarded to Dr. Evelyn A. Rojas for her participation in this clinical practice guidelines for tuberculosis in adults 2020 updates. Thank you, Dr. Eva. So with that, we'd like to thank everybody for joining us in this session, and we hope that this has given us a good perspective of what the treatment, screening, treatment, management, and prevention of TB will look like the next decade or so. Thank you. Thank you very much.